Hello, welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. I'm Rich Duzak from Emory University, and this module is the final part of the series on physician reimbursement operations and the final module as well in Level 5 of Replete entitled Physician Reimbursement Operations, Collections Optimization. This module is targeted to Level 5 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. In fact, this is the last module in the entire Replete curriculum for all trainees except those in nuclear radiology and in vascular and interventional radiology. 2 additional short modules are available for individuals in those 2 programs in order to fulfill all of their ACGME and ABR milestones requirements. The learning objectives for this module are as follows: to synthesize salient, radiology-specific economics and policy knowledge from multiple prior Replete modules, to implement systems-oriented analytic and improvement processes into your practice's revenue cycle management activities, and to identify opportunities to simultaneously provide high-quality patient care while optimizing legitimate revenue, all in a regulatory compliant manner. Here are some additional resources listed alphabetically for those who would like to learn more about the topics in this module. I'm not getting paid for this, or I'm not getting paid for that. Can you help me? It's a question I get not infrequently by not only radiologists from other institutions, but also from my own partners. Over the 30-some modules you've been through in Replete, you've hopefully learned a lot, and hopefully now have the depth of knowledge to be able to help with questions like that in your own practices. So that will be the topic of this capstone-type session, synthesizing many of the things you've heard about in other contexts and things that you already know into a practical approach to optimizing legitimate revenue for your practice. In many practices, radiologists rarely volunteer to serve as their physician revenue champion, making the commitment to work closely with their business team. And so if you're interested in this domain, I would submit to you it's an opportunity for you to establish yourself as your practice's champion and add real value to your practice. And if you apply these principles more broadly to your health system as well. You've seen this flowchart many times so far in Replete, and I'll remind you about it one last time. It's the chain of events that happens before you interpret an examination and generate your report, and the things that happen afterwards that ultimately dictate how much you get paid. And so each and every one of these steps is important. The other way that we've looked at it is illustrated here, the chain of all the things that happen between just doing your work and getting paid for it. And since any chain is only as strong as its weakest link, you now know that there are many, many potential weak links in this one as well. We've talked about many of them before, and rather than me recite all of them yet again, I'll let you read the list. Hopefully you now know a bit about how to answer the various questions that you see illustrated here. We'll plan today to build on that some even more. You'll soon be the reimbursement experts in your practices and will probably get asked these types of questions a lot, just like I do. So I'll share with you my approach to answering some of them, as well as my approach as the physician lead in our department's reimbursement activities as to how I try to guide our team in proactively avoiding these potential points of failure, so as to keep that payment chain strong and intact. Why aren't we getting paid for this? Or why aren't we getting paid for that? If you become your practice's physician champion or leader in your reimbursement efforts, you will hear that question more times than you'd like. And at least for me, my first question back to whoever is asking me this is the following: do you really know that you didn't get paid? Because you can't just react to one anecdote or story. If you're going to really do revenue cycle management right, you need to do it in a methodical and data-driven manner, which means drilling down and then asking some additional questions. By, quote, not getting paid, are you talking about denials? That is, cases where you're not getting paid at all? Or are you talking about scenarios in which you are getting paid, but just less than you did in the past, or less than you think you should? Because they each have very different root causes. And if you're experiencing both of those problems, I would submit to you that you have a really bigger system-wide set of issues going on. Most of the time, the answer I get back to that first question, that is, do you know you didn't get paid for this, is this: Well, I'm not so sure. And so you need to look deeper to find out why you're not sure. Because if you're going to implement corrective measures, you should be sure, or at least have somebody in your practice who is. Ultimately, being able to answer questions about all of these points of failures comes down to doing a good job proactively auditing your revenue cycle operations in an ongoing manner, and doing it rigorously and thoroughly, carefully looking at each step along the way in a lot of detail. What I'm saying should not be a new concept to you. As part of the non-interpretive skills that I'm sure you're studying for as you prepare for your board examinations, you're likely familiar with the PDSA approach to quality improvement. Plan, do, study, and act. And keep repeating the cycle, of course. And that's essentially the model that I'm proposing to you here. What we'll be talking about really is an ongoing quality improvement process, just one that applies to your financial operations rather than your clinical operations. Fortunately, you don't need to reinvent each and every wheel when developing the scorecards necessary to plan and study. But you will need data, because without it, you can't act in a meaningful and productive manner. There are a lot of scorecards that you can use in your practice, but I'll briefly run through the ones that I personally like. And then we'll talk about how to use these to identify issues that may be adversely impacting efficient and appropriate collections in your own practice. One measure, and ideally these are all used together in one way, shape, or form, is to look at collections. It's a simple but unsophisticated and also lagging metric. What's our cash flow look like? How much money is coming in? I'll share with you some examples of this in a bit and show you how, unless you use this measure in a thoughtful manner, you can easily get fooled about the performance of your revenue cycle. The collection to charge ratio is another good one. From modules way back in level 2 of Replete, you now know all about charges. They're the list prices or sticker prices for our services, and not necessarily what your practice expects to get paid. So this is a simple ratio. The numerator is what you got paid, your collections, and the denominator is what you charged. Like the other metrics I'm outlining, this can be a useful tool, but it's just one tool. That numerator to denominator ratio can change, for example, if you get a lot of denials, but also if payers change their fee schedules and you start getting paid at a lower rate. But this gives you a starting place to tease that all out, as we'll talk about in a bit. Days in accounts receivable, or days in AR, is a commonly used measure in healthcare billing. It's not intuitive, so it warrants a bit of explanation. As a general rule, it's calculated on a 6-month rolling basis. And so you first calculate your daily charges over that time by dividing your total charges by the number of days in that window. And for 6 months, that's usually around 182. And then you divide your total amount in accounts receivable. That's the total dollar amount of all the bills you sent out but you haven't yet gotten paid for. And you divide that by the average daily charges amount to calculate your days in accounts receivable. In short, days in accounts receivable is essentially a metric of how long it takes you to get paid. Shorter is obviously better. And in a few minutes, I'll show you an example of how you can track and interpret this metric too. Next is non-payment rates. This is another scorecard that I like a lot, and it's one that's pretty intuitive. This too is a ratio. How many cases did we not get paid for? Divide it by how many cases we billed. So instead of looking at charges in payer fee schedule amounts, for example, they dial down your average chest x-ray professional payments from, say, $15 to $10, it's really much more of a metric of denials in a binary manner. You either got paid or you didn't. And that's perhaps because you didn't get pre-certification, perhaps because the service wasn't covered, or perhaps because the patient was out of network. More too on how to interpret this metric in a little bit. And finally, before we get into examples, one that I really like and that we use in our practice here at Emory is the correct to bill ratio. It's a metric of how automated you can make your coding and billing, and I think is something that will catch on more and more as other practices like ours increasingly leverage artificial intelligence technologies. This isn't a metric that's familiar to many or even necessarily intuitive, so a bit of explanation is warranted. First, by way of background, you're familiar with the traditional approach to coding and billing. You dictate a report, it's read by your coder who applies CPT codes and ICD-10 codes and modifiers, and then sends it through your billing system to an insurer, with the hope, of course, that you will get paid. Now, computer-assisted coding has been around for nearly 2 decades and is gradually getting better, although in my opinion, the currently commercially available products still have a long way to go. Here's how billing works in this environment. First, of course, you dictate your report, and it's uploaded, ideally in an automated manner, into a computer-assisted coding software system that uses natural language processing algorithms and takes its best stab at CPT and ICD-10 coding. So when your coders first see those reports, they now see them in a screen with some provisional codes that they can either accept and then quickly send down the electronic conveyor belt, or modify and correct as they see necessary, and then send on as bills. As you can imagine, current systems do a far better job coding simple cases like radiography and mammography than they do with more complex services like interventional radiology. As practices like ours, and perhaps yours as well, if you join one that really leverages informatics tools, increasingly tweak these engines and refine them and validate them, we can all take this to yet another level. The goal is to automate those simple cases and allow our coders more time to focus on the tough cases. So at least for some, and usually the simple cases, you can bypass human coders altogether, except for audited samples, of course. Now, to do this and also remain compliant requires a really sophisticated working environment and the right culture that is committed to validating strict quality thresholds. In ours, if the computer code assignments are regularly done with greater than 95% confidence for CPT coding and for ICD coding, which, by the way, why did we pick that? Because it's a threshold better than that of most human coders. We then consider those cases, quote, correct to bill, and submit those claims in an automated manner. Obviously, the better the physician documentation and the more consistent the templates and the more straightforward the cases, the more likely that any report will be assigned electronically as correct to bill. More, again, on using this metric in just a bit. With that as an introduction to some of the scorecards, let's go back now to some of the most common failure points in the revenue cycle operations of most radiology practices. You see the list of the big ones here. They're the likely and most predictable failure points, the weak links in our reimbursement chains that adversely impact us capturing legitimate revenue. And so we shouldn't be surprised if we run into difficulties in these specific areas. Indeed, for all of the reasons that we've talked about throughout Replete, we should instead be anticipating problems in these areas. And we want to do it before we are impacted by catastrophic cash flow problems in our practices. Your revenue cycle, like a lot of other organizational systems, is vulnerable to the laws of entropy. That is, if you don't keep investing time and money and energy into keeping things working the way they should, they will often fall apart, and sometimes quite quickly. And so, using scorecards to allow you to identify failure points early rather than late will help you keep your cash flow so that you can maintain a sustainable and successful practice, and minimize as well you having to clean up any downstream compliance messes. And so with that as context, let's now go back to our scorecards and talk about some ways that you can use those scorecards to identify failure points in your practice early, before they became crises. Back to the scorecards then. In the clinical vernacular, you should look at each of these then as a screening test. They're sensitive, but not necessarily specific. But if they're abnormal, they usually merit follow-up. And just like any screening test that you use clinically, to use them well, you need to think carefully about what they measure and what they don't, interpreting them appropriately and using them appropriately. So let's dig in the order that you see them listed here. Let's talk first about collections. This is the first of a series of scorecards that I will illustrate for you graphically from a hypothetical practice. It's a group of, say, 30 radiologists covering several hospitals, and they get reports from their billing company each month that provide, unfortunately, little more information than this. As a result, the partners are essentially trained to only look at their cash flow. And what do they see? Exactly what you see here. Collections are going up over time. Hey, we must be in good shape, some of them say. Because they haven't participated in Replete, though, they don't know that they're looking at an incomplete measure. But you do. Yes, the practice's collections overall in blue are nudging up. But let's dig a bit deeper and look at some things that you will only find if you are deliberate and intentional in your analysis by specifically requesting more granular and actionable data from your administrative partners. So indeed, things are going well in the hospital inpatient and outpatient settings and in the emergency department setting as well, as collectively illustrated in orange here, showing all of your practice's hospital business. On that side of things, yes, the partners can say, we are growing the practice. But something's happening in the private office setting, as you see in gray, something you'll only see if you drill down like we just did here, because it would otherwise get masked by the disproportionate hospital growth that overall gives you a blue line with a slope that's going up. Look at the gray line for your private office site collections. Collections in the private office settings are trending downward. What's causing that? Well, we can't say for sure based upon this graph. It could be, though, payer steerage, maybe pre-authorization issues, maybe competition. How about service issues? Maybe you've got a new scheduler who's giving your patients a bad impression up front and they just don't show up. My point here is that you now have information to allow you to work through this reimbursement differential diagnosis process, so to speak, and target that analysis to this very specific part of the practice, your outpatient office sites. All of this, though, would be hidden if you rely only on thin, insufficient, and overall unsophisticated dashboards. And your physician leaders will only be able to participate in these deep dives if they get sufficient protected time away from the work list, gerbil wheels, to work with their administrative partners in a team-based manner. How about collection to charge ratio? It's a widely used metric, but like any screening tool, it's highly imperfect. What if this were a graph for your group? How would you interpret this? Our charges, you might say, often used as a surrogate of our volumes, are going up. That sounds good. But our collections, here in green, remain stable. So what's going on? Are we seeing more denials? Perhaps a poorer payer mix. Or maybe payers are cutting our rates. Or, and this is pretty common, whoever creates the charge numbers for your practice just arbitrarily jacked up your prices. And so this could all be artifactual, meaning that nothing has changed other than your sticker prices. So don't mistake increased charges to mean that your volume or your service complexity are necessarily all going up. This could just all be an artifact of price setting, something that one of your administrators has done on your behalf. Days in accounts receivable, as I've told you, is a widely used metric in the healthcare billing industry. It's another marker of how well you're getting paid, and specifically how efficiently you're doing it. Here's another hypothetical case to consider. What if this were your practice? Days in accounts receivable was pretty steady throughout all of 2017, but then, in the beginning of 2018, started creeping up. So, you want to look at what happened around then and do it in a targeted way, remembering what this metric measures and what it doesn't. Here are a couple things that I'd think about first. Did your billing company hire some new people who don't know the nuances of your system? If so, you need to get them up to speed before those claims age out. Why? Medicare, for example, won't pay a claim if it's submitted 180 or more days after a service, so you need to stay on top of this. Maybe your billing company updated their billing software, so this could mean there's a problem with that. Or, since we're starting to see a bit of a downturn in July, maybe an expected transition back to a new steady state after the rocky road of a software update. But either way, it merits closer attention. Perhaps instead, though, there are external forces at play, such as a big payer in your market suddenly started dragging its heels processing claims. The time to investigate this, though, was ideally a few months ago when you first saw the upturn. And if you didn't do it then, now is the time. Non-payment rates is a pretty simple metric as well. Did you get paid or not? Again, it doesn't look at how much you got paid, but rather in a binary way on whether you got paid or not. So it largely focuses on outright denials. I think this is complementary to the other metrics I'm showing you. Not surprisingly, these numbers can be very variable month to month, like all of the other metrics, with upward and downward random blips. So you want to look at overall trends. Think about how you would look at this if this was your practice. Around the new year, it looks like your denials started creeping up. But global practice-wide graphics like this make it hard to determine what's going on at the individual service or site level. You know now, though, that I'm going to tell you that you need to dig deeper, and I am. So if you're savvy, and hopefully since you've been now through some 30 of these modules, you are, you're going to ask your billing company to break this down by sites of service, and that's what they've done for you here. The blue line is what I just showed you for your practice overall. Non-payment rates are going up slightly, as you see in blue. The orange line are your inpatient cases, and overall denials there are holding pretty steady. But something is really changing on the outpatient side of things, highlighted in gold. Denials there jumped up big in January and seem to be driving the change that you see in your practice overall. This could be payer steerage, such as Anthem's recent decision to deny services in the outpatient setting of hospitals and only pay for services in lower-cost private imaging centers. Or it could be a marker that something's going on in your practice not doing a good job getting pre-authorization, because pre-authorization, remember, doesn't apply to the inpatient or ED sides of things, and you wouldn't expect those graphs to change. Now, the elephant in the living room here, though, is the gray line at the top. The consistently high denial rates in the emergency department setting. They are super high all across the entirety of this graph, but consistently so. That is, unlike the gold line for elective outpatient services, they're not getting worse. But I'm not sure this is something that you can fix very much, because it largely reflects the nature of providing services in the emergency department. There, denial rates are pretty much universally high all across the country. Here's the abstract from a paper of ours from a few years ago, showing that this is something that happens all across the country. We studied over 18 million claims for over 3,000 radiologists. That's about 10% of the entire U.S. radiology workforce, spanning 40 states over 4 years. And what did we find? We found that denials for imaging services in the emergency department were consistently high across almost all practices in the U.S. In fact, it's pretty typical that 1 in 4 studies out of the emergency department never gets paid at all. That means that big radiology practices covering emergency departments provide a lot of uncompensated services to their communities, averaging about $2,500 per radiologist per month. Something you want to remind your hospital administration of when you're engaged in contract renewals. Not surprisingly, this is partly related to the fact that the emergency department is the access site of last resort for patients, and often those without insurance. So across all modalities, about half of these unpaid claims are attributed to patients without insurance. In that population, only about 6% of all claims are paid at all. That means 94% are not paid. But it's worth noting that in the population of people with insurance coming to the emergency department, and there are a lot more of them than patients without insurance, non-payment rates are not unsubstantial. They're about 16%. A lot of that, I think, is because practices aren't getting good clinical history to support medical necessity, and thus their claims are getting rejected. So there are some things that your practice can do to help its bottom line here, at least focusing on doing a better job managing revenue for your insured patients. Things that we've been talking about ever since the first couple modules in Replete. Let's now talk about one of the metrics that I like, correct to bill. This is largely a measure of how good your radiologist documentation is and how accurately a computer-assisted coding system can assign ICD and CPT codes based upon your radiologist documentation. I think it's probably also a measure of how easy it would be for a human coder to code a case in your practice if, say, your computer-assisted coding software were down. Here's a hypothetical practice that implemented chest x-ray report templates in January of 2018. They picked chest x-rays. Why? Because, like mammography, it's the second most common single imaging service provided by their group. And so they saw an overall increase in correct-to-bill rates for radiography, as you see in orange at that time. And because radiography on a code basis contributes to so much volume in most of our practices, you see that practice's overall blue line correct-to-bill rates nudge up too as a result. But radiologists are very variable in their willingness to adopt structured reporting. And structured reporting is something you know that I think is very important, not just under fee-for-service, but for your practice capturing quality metrics under new value-based payment models moving forward. Here are correct-to-bill graphs for 2 radiologists. The radiologist in green was doing a great job with her dictations all along, and her correct-to-bill rates went up even more after she embraced the practice's new chest x-ray structured reports. But the old guy here in red was never doing quite well, and only begrudgingly used templates after they were implemented. So the practice is using a lot more coder resources to get his claims paid than they are for his younger partner. These are things that you can tease out with good analytics, but only if you look. My intent in walking you through all of these metrics was to help you understand that you need tools to identify the weak links in your reimbursement chain. You will only identify these things if you look. Otherwise, you'll just see your revenue go down and never know what hit you. Again, analytics won't necessarily identify with certainty what's going on, but they will help you narrow your differential diagnosis. And with that as background, let's spend a few minutes, our last few minutes, and talk about these various failure points. They're things that you've heard about before in Replete. We'll just talk about them now in the slightly different context of optimizing your collections. First, pre-authorization. Remember, this is where the RBMs come in, the radiology benefits management companies. It's the mother may I that you need to ask up front. It typically applies to insurance other than fee-for-service Medicare, which may still be a large portion of your business, and typically only applies to advanced medical imaging, that is CT, ultrasound, and nuclear medicine, specifically PET. You saw this flow diagram a few modules back. You need to obtain pre-authorization before you perform and interpret these studies, because if you don't, you'll do all the interpretive work and not get paid. So it behooves you to ask these questions as you look at your practice's workflow, and also ask these if you start seeing trends in your practice metrics that could be attributed to a change in your pre-authorization practices. Meaning, are you checking for pre-authorization at all? Are you asking the right questions about the insurance status, and are you asking it at the right time in this workflow chain? And are you doing this in a team-based manner? Perhaps there is somebody new overseeing this stuff in your practice, or you have new frontline people. And more broadly, are you working with your health system and your regional and your state and your national professional societies to address bad payer behavior? You can't fight this battle alone. Remember from that survey of the American Medical Association of Physicians that I shared with you a few modules back, you'll probably find lots of sympathetic physician partners in your community to potentially join you in these efforts because they, like you, don't like pre-authorization. How about your documentation? I know that I sound like a broken record with this one, but from all of my years doing practice consulting, I regularly see radiologists leaving a good 5% of their revenue on the table because they don't sufficiently prioritize documentation and then develop ongoing systems to capture clinical information in real time. Think about what the average radiologist makes. 5% of that is a lot of money. At the first level, are you including the following information in your reports? Basic stuff, clinical history, technique, and impression. But more than just filling in the blanks, is your information as good as it could be? That is the clinical history understandable to your coders and potential auditors? How about your technique section? Are you using jargon that they don't understand? And how about the impression in your report, where your coders will look first when they ICD code your cases? Is it as understandable and unambiguous as possible? Let's run quickly through a few cases. This is something that we do on a regular basis in our practice, and I think you should as well. Here's a fictitious report for a chest x-ray, and I'll run through a few variants. First, the CPT coding. There's a good description of what got done, so your coders will be able to assign the right code for a 2-view chest, meaning rather than a 1-view chest here, 71046. And remember the rules of ICD-10 coding. Coders are supposed to assign codes to the highest level of specificity with regard to signs, symptoms, and diagnoses, in that hierarchical order. So they'll look first at your impression. Here, they won't find anything codable because the study's normal. And that's okay. Why? Because your staff did a good job capturing this information and you did a good job putting it in your report, meaning your clinical history. And so your coders will be able to assign 2 payable ICD codes for this chest x-ray. All is good. How about variant 2? The ICD-10 information is all the same, but the report never indicates that this is a 2-view chest. Remember, for radiography, it's the number of views that matters. And in the setting of an ambiguous report, your coders will take a de minimis approach to CPT coding. And here, code only 71045 for the single-view chest, rather than the higher-paying 71046 for a 2-view chest. So this practice left just about 20% of their legitimate revenue on the table, just because they didn't have good template matching and because their radiologist never corrected this inaccurate auto import. Variant 3. This radiologist used a template and confirmed in signing the report that the study was a 2-view chest. That's good. In this case, there was a specific diagnosis in the impression for the coders to use, pneumonia, and so that's how they'll code ICD-10. And that's good as well, because the practice didn't capture any signs or symptoms. Had this been a negative examination, this practice would not have gotten paid. No history, no impression. And so cases like these, even if you got paid, should still be flags that you have some systems problems. Capturing this information from your referring physicians, from your schedulers, from your front desk clerks, and your technologists requires ongoing education and reinforcement. Remember my entropy slide from a few minutes ago? This is a good example of what can happen there. And finally, here's another two-view chest, with no specific diagnosis in the impression, but signs and symptoms in the history section. Nominally, that's enough to get some diagnoses to get paid. Based upon that information, this case could be ICD coded as cough and shortness of breath based on signs and symptoms. But take a closer look at the report. There is a specific diagnosis buried within, atelectasis. That is a codable diagnosis. In many practices, this would be kicked out by the system by computer-assisted coding algorithms, as well as by human coders, because they'll question whether, by just using signs and symptoms, you were providing them the most specific diagnosis they need to follow ICD-10 rules. My point here is that for coding purposes, your impression should include any relevant diagnoses, even if they're minor ones, and simply stating things like no change. Leave your coders in the same predicament. It's far preferable to say unchanged CHF or unchanged pneumothorax or the like, so that you're conveying a specific diagnosis to your coders as well as your referring physicians. Coding, of course, is intimately related to documentation, and so we'll be able to run through this one pretty quickly. Coding errors can happen for two reasons. We've already talked about deficiencies in documentation. In these cases, you haven't given your expert coders the information they need to best do their jobs. But we haven't talked about coders making mistakes, because even the best ones do make occasional mistakes. We're all human, and so this should be expected. Where you can get into trouble, though, is if you don't hire appropriately trained and certified coders and don't provide them opportunities to continue to learn and maintain their certification. You may remember back in the fraud and abuse module that I told you that you weren't going to be held personally responsible for coding for each and every case, but you will be held responsible for making sure that you have instituted appropriate practices to ensure accurate coding. And that's where coding certification comes into play. There are a lot of bodies out there that claim to certify coders, but only one, the Radiology Coding Certification Board, focuses specifically on radiology and has board members from the American College of Radiology and the Radiology Business Management Association, holding the organization to the highest standards. And so I would encourage you to utilize coders certified by the RCCB. You'll recognize them by the RCC, Radiology Certified Coder, credentials that they use after their names. It's important as well to use those highly trained individuals as part of your team, rather than at the back end just trying to clean up your physician documentation messes. As such, engaging them as part of your overall revenue cycle management operations efforts will serve you well. Their feedback will help you optimize legitimate revenue and help keep your practice out of trouble on the compliance front. And finally, don't forget to consider up front whether a service is covered, because if you're offering services that aren't covered by Medicare or other payers and you're not getting ABNs, remember, advanced beneficiary notices up front, then you probably won't get paid for those services. These issues happen much more frequently in academic centers, where we tend to provide a lot of cutting-edge services, but many large and advanced private practices are providing many of these cutting-edge services as well. And so you should make sure that everybody on your team is aware of coverage policies, particularly if you're implementing new services. Make sure that you ask yourself these questions when you bring on new service lines. First, make sure that you've got this issue on your radar at all. Are your partners thinking about payment when they promote a new service or a new technology? And when you start thinking about these new services, do some homework and find out if there's a CPT code for that service yet. Because if there's not a Category 1 code, you know from prior modules it's probably not going to be payable. But you also know from our prior story about CT colonography and some other services, even if there is a Category 1 code, there's no guarantee that you'll get paid. So you'll need to check all of your payers' websites and maybe make some phone calls as well. Because if you don't, you won't know to get ABNs from your patients. And if you don't get ABNs up front before you provide non-covered services, then you won't be able to bill your patients for those services. In summary, then, appropriate physician payment is predicated on a complex chain of events and only as strong as its weakest link. Understanding that chain and its points of vulnerability will permit a radiology practice to optimize its revenue management activities. And as with many things in healthcare, the revenue cycle is best led and managed in a proactive and team-based manner. Those summary points are pretty much the same ones I highlighted some 30 modules ago back in Level 1, and that's because we have now come full circle in Replete. Hopefully you now have a much deeper understanding of all of these issues. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the Replete initiative and additional resources are available on the RSNA's website. But for those of you in all ACGME training programs other than nuclear radiology and vascular and interventional radiology, these 5 levels of Replete that you've now completed should satisfy all of your economics milestones requirements. And for those of you in nuclear radiology and vascular and interventional radiology, please take a look at the very short, specialty-specific supplementary and complementary modules available on the RSNA's website. I'm Rich Duzak from Emory University, and I very much enjoyed leading you through your economics and health policy milestones journey. Thank you for participating in Replete.